All right. Well, welcome. I'm Jill Holt with Mountain Pacific, and I want to thank you for joining the webinar today. We're pleased to be featuring, this is an MDS webinar, of course, and we'll be featuring sections K and M of the MDS. And so next I'd like to introduce Tim Kozad. He's a licensed practical nurse and long-term care lead surveyor for Wyoming's healthcare licensing and surveys, as this program has been sponsored by the Wyoming Department of Health. So Tim, I'll hand the floor over to you.
Thanks, Jill. Welcome, everybody. I have the privilege of introducing our speaker today. Jennifer LeBay is a curriculum development specialist with APACN. She's been involved in the RAI process since 1997 and has been in post-acute care arena since 1991, serving in a variety of capacities, including CNA, charge nurse, MDS coordinator, and regional corporate clinical reimbursement specialist. Jennifer has considerable expertise in the MDS 3.0 and RAI process and the prospective payment system, or PPS, and ICD-10, including the clinical and financial aspects. So with that, Jennifer, take it away.
Well, thank you so much, Tim, and everybody for having me. Very excited to be with you today and to dive right in to hopefully clear up some issues, questions, coding concerns associated with sections K and M as they relate to nutrition and wound assessment, especially, and coding. A little housekeeping. I have no relevant financial relationships to disclose. I will not be promoting any commercial products or services during the presentation. And during this 1 hour long webinar, we are going to discuss the MDS coding instructions for sections K and M, and we'll talk about the differences between the stageable versus unstageable pressure ulcers and injuries. The main focus is going to be really making sure that we have a good understanding of that whole skin process, nutrition, how it relates to the skin, and how that needs to be coded on the MDS. We'll also talk about some common resident changes throughout these sections that may result in a significant change in status assessment, and how to not miss those items. So let's talk about the significant change in status to start. So significant change in status is going to be an assessment that is required if there is a change in the resident's care that is going to require an overview of the plan of care. It needs to affect at least 2 areas of the resident's overall status. And what we're looking at as we go through section K and section M will kind of highlight the different areas that may seem small when you first look at them, but digging a little deeper perhaps may end up being something more that would require that overview of that care plan and adjusting things to establish that new baseline for that resident. So a significant change in status, the final decision related to whether we should complete a significant change in status, that's going to be based on the judgment of the interdisciplinary team. There are no specific guidelines in the REI user's manual that tells us it's a significant change if X, Y, and Z occur. There's a few guidelines in there, but basically the government says we should be using our clinical judgment as a team to determine whether this really meets the criteria. MDS assessments are not required for minor or temporary variations in the resident status. So if this is something where the resident's expected to return to their baseline essentially within 2 weeks. So basically what we're looking at is there's an issue, there's a change, something is different with how the resident was assessed on the previous OBRA or scheduled PPS assessment, where it's something that's been submitted and we're looking at, gee, there's something different here. Well, it doesn't necessarily mean you have to do a significant change in status assessment right away. We need to review that resident for a couple of weeks and say, okay, is this just a temporary thing? Is this a transient condition? Is this something that they're going to bounce back to their baseline within 2 weeks? If within those 2 weeks, there's no return to their baseline, and now we have established this is a significant change, the staff needs to address that in the medical record, and then a significant change in status assessment is required at that point. But if there are transient changes in between, that doesn't mean we don't document it. It still needs to be documented in the medical record. There still needs to be interim care planning associated with that change. And there may be doctor's orders or medications or treatments that are going along with these transient changes that certainly we need to make sure that we're addressing. The minimum data set and the REI process is just that. It's a minimum. It's not going to cover every single possible thing that's going to happen with this resident 24/7. The MDS is looking at a snapshot in time. So when we're looking at that snapshot that was last assessed, we need to make sure that this is accurate for a new baseline for this resident. So there are a lot of areas that could impact whether we do a significant change in status or not. As I mentioned, it's 2 or more areas of decline. And when we're talking about areas, it's not just, oh, there's a change in section M, there's a change in section K. It could be within section K. It could be within section M or any of the other sections of the MDS for that matter. That could meet that criteria. It could be a decline. It could be an improvement. So maybe on the previous assessment, they had 2 stage 2 pressure ulcers, and now they have none. That could be enough for a significant change in status if there's no other things going on. If there's only one change, there is still a possibility that a significant change in status would be appropriate. That's going to be an interdisciplinary team discussion to say, hey, you know what? They've got this wound, maybe they're borderline with their diet, maybe they haven't necessarily shown a weight loss, but their weight is fluctuating in between those observation periods. Maybe this is something that we would want to address and go maybe establish a new baseline care plan so we can address these things. Every resident is unique. Every situation is unique. Every, what could be a sig change for one person may not be a sig change for another person. So it's very important to really understand the resident and really understand the coding instructions and what we're looking for when we're talking about what is this change, and then having this discussion as a team. Whether you decide to proceed with a significant change in status or not, that needs to be documented in the medical record, especially if you are going to be proceeding with that significant change in status, because that notation in the medical record is going to determine when that significant change in status is due for completion and then submission into the federal repository. You can find more details on the significant change guidelines in the REI User's Manual on the pages listed on your slide. And we've got our long-term care facility resident assessment instrument 3.0 User's Manual. We are currently in version 1.17.1, last updated October of 2019. It usually is updated annually, but there's been something going on for the past couple of years that has kind of prevented anything else from happening other than the big bad COVID related stuff. But there will be an update coming next year for sure. There is a new draft out, as some of you may have seen. So bet your bottom dollar we'll have a draft REI User's Manual update, hopefully in early 2023. One can only hope, because there's quite a few changes. The item set that you are currently working with is item set 1.17.2. That is effective October 1st of 2020. And that was added in order to allow states who collect PDPM data for their OBRA assessments to do so. Not every state does, but that's why there's a difference in versions between the REI User's Manual and the item set. There were a couple of errata documents that were released in the past couple of years. Neither of them are going to necessarily impact what we're talking about today. It's more of PDPM related items for NTA points, and then section I, coding on schizophrenia. But those are the current versions. That's where we are. Let's dive into section K. So the first item in section K is swallowing disorders, and this would be any swallowing disorders that occurred during the 7-day look back period. So we have our assessment reference date. We count 7 days, 7 calendar days back. This is all going to be while a resident. So if we have a shortened look back period because maybe you decided to choose day 5 as your admission assessment or for your PPS assessment, it's only going to go back to that upon admission date at A1600. So what we're looking at here is any signs and symptoms of a possible swallowing disorder noted in that time frame. The rationale for this item is that the ability to swallow safely can be affected by disease process and functional decline. What we're looking at here is an all cause. So there doesn't have to be a specific diagnosis in place related to a swallowing impairment. What we're looking at here is there the potential for them to need further intervention or have maybe some care planning that puts them at risk. There is some very large components to the PDPM payment system in this section, but from a care planning standpoint, if you have somebody who has any of these items, that is certainly going to potentially impact. I know I have, if I choke on something because I had a good guffaw during, my lunch break and something went down the wrong pipe, I certainly have a sore throat after. The nose starts running, the eyes start watering, and that could potentially put me at risk for doing it again. So we think, if we think to our clientele that are in the facilities, any of these things, regardless of why it occurs, it could definitely put them at risk for some problems, and maybe be the first indicator of further problem that needs further review, whether it's by speech therapy or dietary or physician intervention, and looking at a diagnosing of a condition that maybe we didn't realize they had, but is just starting to present itself with a swallowing impairment. So again, this is a 7-day look back. We are observing the resident during the meals and any other times when the resident is eating, drinking, or swallowing to determine if any of those listed items of possible swallowing disorders are exhibited. You want to interview staff that work on all shifts. It doesn't just have to be the CNA that was working with the resident that day on the day that you are doing your MDS and trying to find out. A lot of times, maybe the dietitian or dietary staff complete section K. And depending on the size of your building, maybe you have a consultant that comes in, maybe they only come in once or twice a week. And if they're only interviewing the staff that's there on the day that they're there, maybe that staff member didn't stay with them the entire time, because we're looking at, we have to remember, anytime we're looking at these observation periods for review, it's a 24/7 look back, or however long your look back period is. It's not just what happened on the day shift when I happen to be here to interview the staff. So it's very important to make sure that we're truly getting the full picture. Looking in the documentation, talking to the CNAs on all shifts, talking to the family members, talking to the resident. They certainly, if you have a cognitively intact or fairly intact person, they can tell you if they, experienced any of these things. Ideally, we would want it documented, because obviously everything that's coded on the MDS needs to be supported by documentation, with the exception of the scripted interviews, of course. But we want to make sure that we have the supporting documentation to say this happened. We don't have to explain why it happened. We can explain that later, but it happened, and here's where we're going to capture this. So we need to look at those off shifts, talk to those off shifts, what's going on in the middle of the night. I mean, certainly somebody wakes up, they're groggy, they're thirsty, they're laying down. these are the types of things that we need to capture, because this is going to potentially put them at risk for further problems. So make sure that we're reviewing all of the areas, the medical record, talking to the staff, talking to the family, talking to the resident, to make sure that we have a full picture of what's going on here. K200 records the resident's height and weight. The rationale for this item is that diminished nutritional or hydration status can lead to debility and adversely affect health, safety, and quality of life. The height and weight are used to calculate the BMI, which is used to determine if the resident has a healthy weight. This happens in the background, so this isn't something you're going to see on the MDS itself. But we do want to make sure that we have a good understanding of the timeframes for both height and weight, and how to calculate these. The resident's weight recorded at K200B is based on the most recent weight in the last 30 days. So this sometimes gets misunderstood by folks that are doing it, because we're so used to having an assessment reference date, and then our count of the observation period is back from the assessment reference date. Well, that is the case when we're collecting the weight. We need to make sure that we have had a weight that was completed and assessed within that 30-day window. If there were multiple weights done within that 30-day window, you're going to choose the weight that was closest to the ARD of that assessment. If the last weight is more than 30 days prior and you're still within that observation period, you can get the weight as long as you're within that time frame. But if it's beyond the ARD and there's no weight in that 30-day window, you don't weigh today for a weight that should have been with an assessment reference date of last week. So unfortunately, that would be a situation where you'd have to dash, and that is not a good thing to have a dash, because A, we're not assessing the resident. We're not getting a full picture of what's going on with them. Weight is certainly a large indicator of many things: their nutrition, their health, their mobility, lots of different things going on. So we want to make sure that we are assessing that properly in that time frame. And once you determine what weight you are using on the MDS, I recommend jotting down the date. A lot of softwares have some sort of notation process in the software, or maybe you can document it somewhere, but that date is going to be important, the date when that weight was taken. And the reason being is the documentation of weight loss and weight gain. So weight loss at K300 documents weight loss of either 5% in the last month or 10% in the last 6 months or 180 days. The rationale for this item is that weight loss can cause debility, adversely affect health, safety, quality of life. For residents with morbid obesity, however, a controlled weight loss could improve mobility and health status. So it goes both ways. Also, residents with fluid overload could benefit from a controlled weight loss through careful diuresis. We need to make sure that we have a good understanding of this time frame. So as you can see here, this item compares the resident's weight in the current observation period with his or her weight at 2 snapshots in time, at the point closest to 30 days preceding the current weight and at a point closest to 180 days preceding the current weight. So it's not 30 days from the ARD, it's 30 days from the date that that weight was obtained. So if that weight on your current assessment was obtained 29 days prior to the ARD, then your count for that 30-day look back is 30 days prior to that date, which is 29 days from the ARD. So it gets tricky. You really have to know the date of that weight. And then the snapshot is looking at the point closest to 30 days preceding the current weight. It's not before, it's not after, it's closest. So there's a lot of wiggle room with this, unfortunately, and I think a lot of folks get confused with it. So our steps for assessment: you are going to identify the resident's weight at that point closest to 30 days preceding the current weight. Then you are going to identify the weight closest to 180 days. You're going to do a determination: do we have that 5% loss in that 30 days? If that 5% loss occurs, you don't have to do the 10%. If they don't have that 5% loss, then you would then have to calculate that 180 days. Once we've determined that there is or is not a weight loss, we have to determine, if this is a weight loss, is this a prescribed weight loss, a physician prescribed weight loss regimen? This is something that a lot of times gets confused as well, because when we say physicians prescribed, that means it's happened before the weight loss actually occurs and it was a plan. Not that, ooh, they lost weight and they were a little overweight, so they needed to, so it's a good thing. If it was not prescribed by a physician, not just the dietitian saying it, but prescribed by the physician prior to the weight loss occurring, we would then have to say that yes, they had the weight loss and they're not on a physician's prescribed weight loss regimen, which could trigger some issues. So we want to make sure that we have the documentation in there. If this is a planned weight loss, that the physician has documented this. So if we're doing a weight loss for diuresis and we get an order for that diuretic, we may want to add to that, or ask the physician to add to that documentation that weight loss is expected, fluid weight loss is expected. Or if they're going on a calorie reduction diet, that weight loss is expected, and that is the plan. I do see a couple of questions in the chat, so I'll take a quick pause to take a look at those. We have some residents that often refuse to get their weight done. So if they haven't had a weight in, say, 60 days, that's okay. Well, yeah, you would just have to document it. You'd have to dash it, because that's the not assessed. Unfortunately, you are going to get an error when you submit to the Keys ASAP system, and that's going to tell you that you have a potential financial trigger. That's only going to impact your PDPM assessments, your PPS assessments, but it triggers for everybody. So if you do get that error, if it's not a PPS assessment, you don't have to worry about it. As far as errors are concerned, you do need to make sure that you have the documentation in place to support that you're attempting, the resident has refused, or if you have it care planned, there's many people who don't have a weight done because of maybe you don't have the right scale, maybe they're morbidly obese, they don't want to be weighed, they have fragile bones, they're at end stage of life, whatever it is. That would be something that you would have care planned, and make sure that you have the documentation to support why you coded the way you did. It may still trigger as an issue either in the Keys ASAP system or upon review come survey time. But as long as your documentation tells the resident's story, that's what we're looking for. We want to make sure that we're taking proper care of the resident and have a proper care plan in place. Another question I see in the chat, we have to document refusals on a couple residents since they won't agree to weigh. We document the refusal, look at their intake, and document that they have got. That's exactly what you need to do. You have to tell the story of that resident. It's not always going to be reflected in the weight, but have that documentation to tell the story. Another question, do we not need to look at 90-day significant weight changes, only in 30 and 180? That is correct. So a lot of times your dietitian will do that, look back, whatever look back they look at, but for MDS coding purposes, it is only the 30 days back from the date of that weight that was used for that assessment, and then back 180 days. They could go up and down and fluctuate in their weight all day long in between, but it's not going to be coded on the MDS. Now, that does not mean that you're not going to have it documented and care planned and interventions in place if that is something that is impacting the resident. You may also want to look at, is there something else going on? Do they have a swallowing impairment? Are they, not feeling well? What else is going on? And that could potentially trigger part of that significant change in status as well. So when you have that weight loss, we need to kind of dig a little bit deeper and say, okay, why are they having this weight loss? Are they having a decline in another area? And that could be enough to trigger your significant change in status assessment. Great questions. Weight gain item K310, very similar to the calculation for the weight loss. We're again looking at a 5% in 30 days or 10% in 180 days, same snapshots in time. Again, we're looking at the date of the weight that was used on that current assessment, counting back approximately 30 days, approximately 180 days. The rationale for this item is that weight gain can also result in a debility and adversely affect health, safety, and quality of life. We're looking at that current weight to see, is there an issue? Now, some people, a weight gain may be a good thing, but some people maybe not. So what we're looking at is the current weight greater than either the preceding weight 5% or that 10%, then you're going to continue with that calculation and say, is this resident, yes, they have had that weight gain and they're on a physician's prescribed weight gain regimen, or yes, they've had the weight gain and they're not. So again, this has to happen before that weight gain actually occurs in order for you to capture that as a physician's prescribed weight gain regimen. So I see some more questions. Can we use a weight that is less than 30 days from the ARD, example 20 days prior or 45 days prior if it's 5% or 10%? So a 10% weight loss in the 45 days. Well, it's going to be a 5% weight loss in the approximate 30 days or a 10% weight loss in the approximate 180 days. Now, if the weight that is closest to 30 days is 45 days ago, that's going to look at the 5%. And then you'd have to go back to the 180 days and the whatever weight is closest to 180 days prior to that weight. 45 days would be closer to the 30 days than the 180 days. You start with the 5%. I mean, if you're at the 10%, you meet the 5% for the 30 days anyways. So yeah, this is a really tricky look back. I don't know why they've made it so tricky, but it is. So we just have to be mindful of that and make sure that our documentation supports what's really going on with the resident. Obviously, we've got to capture those things in between to make sure that we're taking good care of the resident. What documentation do you recommend from the provider? Something as simple as weight loss is recommended or something more specific? Well, from the physician, why do they want them to have the weight gain or the weight loss? There's got to be some rationale behind it, ideally. You know, we don't want to just say, yeah, it's okay for them to gain weight. Well, we want them to gain weight because they're underweight or they have skin issues or why do we want them to gain weight? Just a simple statement of this is expected isn't really telling the full clinical picture. A lot of times your dietitian is going to do a really nice assessment as to, you know, their current caloric needs or their, you know, ideal body weight and, you know, all of those fun calculations that they do in their assessments. So, you know, kind of have the provider piggyback off of that. You know, why is this recommendation being made? Not just, you know, for the whim of it so we can code the MDS appropriately and not get dinged for something. But why clinically is this necessary? And I had already mentioned they have to be on that planned weight gain regimen before. The next item documents nutritional approaches in the last 7 days, including parenteral or IV feeding, tube feeding, mechanically altered diet, or therapeutic diet. So there are a couple of different columns here. While not a resident is going to be anything that happens outside of that admission date at A1600, that entry date. If your observation period, if you're doing this assessment and they've only been in the facility 5 days, then the 2 days that they were not in the facility to make that full 7 days would be coded as while not a resident. And then once they've come into your facility while a resident will be what you code in column 2. If this assessment is being done on day 14 of the stay or day 120 of the stay, obviously they've been in your building longer than 7 days, so you're not going to have the opportunity to document the while not a resident column. K510A parenteral IV interventions, the amount of the IV fluid does not determine the coding at K510A. the reason for the IV fluid is the determining factor. So what we're looking at here is any IV fluid or parenteral IV fluid or nutrition that is being used specifically for nutrition or hydration purposes, not just to reconstitute a med, not just to flush, not for any other reason. There needs to be documented reason and clinically indicated need for this additional fluid via this route. This could be IV fluids, it could be hyperalimentation, it could be total parenteral nutrition. IV fluids keep running at keep vein open rate, but again, there's got to be documentation to say this extra fluid at the keep vein open rate is for nutrition or hydration purposes. IV fluids contained in IV piggybacks, if it's documented that it's needed for nutrition or hydration. Hypodermoclysis or subcutaneous ports in hydration therapy, even though it is not parenteral or IV, this does count here. So if you're doing those subcutaneous ports that have hydration therapy and it is for hydration or nutrition purposes, you can capture that here. A lot of folks don't realize that. Therapeutic diet, feeding tube, mechanically altered diet are the next items. Feeding tube is the presence of any type of tube that can deliver food or nutritional status fluids, medications directly into the GI system. This could be nasogastric, gastrostomy tubes, jejunostomy tubes, PEG tubes. Mechanically altered diet is a diet specifically prepared to alter the texture or consistency of food to facilitate oral intake. So feeding tube solution does not count as a mechanically altered diet. What we're looking at is, soft solids, pureed, ground meat, thickened liquids counts as mechanically altered as well. And then therapeutic diet. Therapeutic diet is a diet intervention ordered by a healthcare practitioner as part of a treatment of a disease or clinical condition. So we have a low salt diet. We have a diabetic diet. We have a no peanuts diet because they have an allergy, or no tree nuts diet, or they, were avoiding a diet because of some other allergy or items. That's what we're looking at here. Just because somebody is on a supplement doesn't mean that they're on a therapeutic diet, but that person with the supplement could be on a therapeutic diet, but the supplement in and of itself doesn't make that a therapeutic diet. I see a question in the chat. Would you count a finger food diet as mechanically altered diet? It depends on what type of food it is. I mean, if you've got a pureed salad, like chicken salad or something that's mechanically altered as part of a sandwich, then yeah, I would say that that's mechanically altered. But you really need to look at what is the diet order. If the diet order is just for finger foods, it doesn't necessarily mean it's mechanically altered. What are they doing to actually change the food to make it finger food? Usually it's just, cutting into small pieces. We're not mechanically altering, like putting it in a blender or chopping it fine or grinding it up or thickening it. I would not consider just a finger food diet order as a mechanically altered. There could be built into that, but in and of itself, no. K710% of intake by artificial route. So if you answer K510A, IV parenteral, or K510B feeding tube, then that is going to open this item, which is asking for the percentage of calories that are coming from either the tube feeding or the IV. And then the average fluids per day. So we've got two columns: while a resident and then during the entire 7 days. There used to be a column 1 while not a resident a while back, and they took that off, but you still need to know what happened while not a resident in order to calculate that final column of during the entire 7 days. That's only going to impact if you have a resident who's at the beginning of their stay. And again, you choose day 5 as their assessment reference date. The 2 days prior are going to be while not a resident. So we're looking at what happened while a resident and then what happened in the entire 7 days, where you would have to look at what happened in the pre-admission period in order to calculate that. So you're determining the total calories the resident received through the parenteral IV or feeding tube, and then comparing that with the percentage that they took in by mouth. So there'd have to be a calorie count done. You'd have to know the calories that were provided in that tube feed solution or IV solution. This is when you're kind of happy that the dietitian is there to do that for you. Otherwise, you're going to have to do all of this calculation on your own and determine, do they meet that criteria, either 25% or less, 26 to 50%, or 51% or more of their calories coming from that tube feed or IV. And then again, looking at the fluid. So you'd have to look at that average. These are averaged. If they've only gotten a couple of days of fluids or parenteral nutrition, you still have to do that math dividing by 7 because it's an average across the full 7 days. So you really need to make sure that you have the documentation, especially while not a resident, to support what were they receiving, number of calories, caloric intake by mouth, cc's taken in, to do this calculation appropriately. And if there's a change, this is another area where a significant change could be triggered, because if they, were taking in 25% or less, and now all of a sudden they're taking more, well, what's going on? Why do they need more through the tube than what they had last time? Or why are they getting less than what they had last time? And then you need to look around and say, oh, well, there's this, plus they've, got a skin breakdown now. So that could impact just a very simple thing, one stage 2 pressure ulcer, and now their caloric intake from the tube feed has gone up a little bit. That's certainly enough for a significant change right there. And then we have some additional training. Section K is part of the SNF QRP, the quality reporting program, quality measures. So CMS has really focused a lot of training on those different MDS items that impact the SNF QRP. But it also will help us in making sure that we're coding correctly, and not missing out on something that perhaps we didn't understand. So I do recommend any extra training that's there to help kind of cement that understanding of these sections. I see a few questions in the chat. Let's see what we've got. Total fluid per day. How do you code if they received 1,000 milliliters a day for 1 day and then nothing? So then you're going to have to divide the 1,000 milliliters divided by 7, and then that's going to be your average per day. So it's always going to be a division by 7, because that's what you're looking at, is the average over 7 days. And another question, would a therapeutic diet include a Jewish woman who has many diet religious requests and instructions? It could, yeah, it could, because there's certainly some things that are, potentially, well, I guess it would all depend on what the outcome of that is. If it's just for religious purposes, probably not, because it's not treating anything. It's just their preference. But if there was something associated with that that's actually impacting them, I would say no. If it's just a religious preference, no. If they had an allergy, if they had a reaction, if they had, something negative happened, if they ate that physically, not spiritually, I wouldn't call that a therapeutic diet. Certainly it has to be care planned. Certainly that's, cultural competence. That's a big one. So that definitely needs to be care planned, but I don't think I would call that a therapeutic diet unless there was something else physically that they were trying to alter or prevent with that diet. We have liberalized menu with several CCHO orders. We are told not to market as therapeutic diet because the RD will determine any intervention such as half portion carbs. I feel tempted to market as a therapeutic diet when we give half portion carbs to CCHO diets. Well, if the dietitian is saying that it's for a specific reason why they're doing half portion, is it Is it a weight issue? Is it are there other issues associated with that? Basically what we're looking at with these therapeutic diets is, are we giving them this diet to alter or prevent something physically in their body? So that may need to be a further discussion between your dietitian and in the physician, perhaps, to say what is the reason behind this. Is it a weight thing? Is it what other issues are we trying to avoid by having those half portion carbs? That's a tricky one without knowing all of the details. So hopefully I helped to steer you in the right direction. All right, let's move on to section M. We are still in that same REI user's manual. And when we're looking at section M, skin conditions, before proper treatment and wound management can be determined, you first have to know what it is we're looking at. You can't treat something if you don't know the underlying cause or the etiology, because there's going to be a big difference between what's going on and how to treat the resident with a stage 1 pressure injury versus what could potentially be a deep tissue injury, which may advance very rapidly and differently. Only selected skin types of skin conditions are captured. Again, this is a minimum data set. It is not every possible thing that could be happening to the resident's skin. Cuts, lacerations, rashes are not coded on the MDS, but they certainly have to be care planned. We certainly have to treat them. If we put every possible thing that the resident could have on this MDS, it would be much longer than 51 pages and some odd. So skin problems are coded if they were present during the 7-day observation period, even if they were present and coded on a previous MDS assessment. So some people are concerned that, oh no, I've coded this on the last assessment. I don't want to double dip. If it's still there, it's still a problem and we still have to capture it. So we're looking at different snapshots in time. In this snapshot in time, they had the wound, they had the skin condition, we're going to code it. M100, MDS completion is based on a fixed observation period ending with the assessment reference date. And if the determination of risk was not completed prior to the assessment reference date, it would not be coded here. So we're looking at the different items that would put the resident at risk for skin breakdown. If they already have a stage 1 or greater wound, or a scar over a bony prominence, or a non-removable dressing or device, they're already at risk because they've already got the wound. They potentially already had one because there's a scar there, and who knows what's underneath that device. A formal assessment instrument. So we did a Braden, a Norton Plus, but again, that would have to be completed within that 7-day window. So if you do it on day 1 and your ARD is day 8, that Braden or Norton did not get done in that 7-day window. One of those two should apply, and if they don't, clinical assessment should kind of cover everything else. Clinical assessment is not just looking at the resident's body, but also reviewing the medical record to determine if there is any risk. So unless we've done no assessment whatsoever of their risk, at a minimum, clinical assessment, if you've done that chart review, if you've reviewed that medical record, if you've looked at the resident to determine that they're at risk, it should be kind of rare that none of the above would be coded unless, the resident was in and out within hours and you didn't get a chance to do the skin assessment because they wouldn't let you. But that would be pretty rare that you wouldn't be at least looking at their skin and doing some sort of a chart review to assess. It's very important to do a head to toe exam observation to look for these different risk factors. Impaired decreased mobility, decreased functional ability, comorbid conditions, if they have end-stage renal disease, if they have thyroid disease, if they have diabetes, if they have some, neuropathy, if they're on drugs like steroids that could affect wound healing, if they have PVD or impaired blood flow, refusal of some aspects of care, if you're not able to look at their skin or check them out after that could be a problem. Cognitive impairments, the residents don't understand what it is you're trying to do. Obviously, urinary and fecal incontinence, huge risk factors for skin breakdown, undernutrition, malnutrition, hydration deficits. We talked about those things in section K. And then if they have a history of healed pressure ulcers, obviously if they had one, well, now they're automatically at risk, especially in that same location, because when the wound heals, it's not the same stuff that was there before the wound occurred. We have to understand some definitions. Healed pressure ulcer, completely closed, fully epithelialized, covered completely with epithelial tissue or resurfaced with new skin, even if there's some surface discoloration. Pressure ulcer injury risk factor. So we talked about those different items on the previous slide. And then pressure ulcer injury risk tools, we talked about those as well. So this, one of those formalized tools. M300 is staging the wounds that are present. M210, we said, asked, are there wounds? M300, what are they? So when we're looking at our wounds, we're looking at stage 1, stage 2, stage 3, stage 4, and then there are 3 unstageable wounds that would be assessing and coding on the MDS. General guidelines when looking at the wounds, there is no reverse staging. If you have a stage 4 pressure ulcer, it is going to stay a stage 4 pressure ulcer until it is completely closed and epithelialized, even if it just looks like a little pinpoint opening. If it was a stage 4, it's always a stage 4 until it is completely closed, epithelialized, and healed. The growth that is happening underneath is very different. So that puts them at much greater risk for skin breakdown in the future. For the purposes of coding, determine that the lesion being assessed is primarily related to pressure and that other conditions have been ruled out. So you could have multiple conditions going on, but if pressure is the ultimate cause, even though it may have been exacerbated by other conditions, peripheral vascular disease, diabetes, whatever, that pressure was the primary cause of it. Sure, it was, like I said, exacerbated by those other things, but pressure was the ultimate cause. If pressure is not the primary cause, then you need to look at what is this? Is this an arterial ulcer, a venous ulcer, burns, diabetic ulcer, some other wound issue? So we have our definition of our pressure ulcer injury. This is where we're going to be looking for sig change. There's sig change potential throughout this entire section, no doubt. Pressure ulcer injury, localized to the skin, underlying tissue over a bony prominence, pressure combined with shear. We need to review the medical records, speak with the nurses who actually have seen the wound, or look at it yourself. As the NAC, you certainly can go out there and take a look at the wound, perform that head to toe full body skin assessment. Facility wound nurses, outside consultants should be made aware of the Section M guidance. And you want to focus on bony prominences and pressure bearing areas, sacrum, coccyx, trochanters, ischial tuberosities, heels, back of head, elbows, skin under braces, anywhere that there's pressure. You want to search for areas that differ from that surrounding tissue, which may indicate a deep tissue injury versus that stage 1 pressure injury or stage 2 intact blister. Pain, firm, soft, warmer, cooler, color change. So we need to decipher which is this, staged or an unstaged deep tissue injury. So we got some nice pictures here. There was a presentation that CMS put out, oh gosh, over a decade ago, and they had some fabulous pictures. So I borrowed those from that presentation. Stage 1 pressure injury is intact skin with non-blanchable redness of a localized area. Darkly pigmented skin may not have the visible blanching, but the color may differ from the surrounding area. So this is what a stage 1 would look like on the 2 different skin tones. Then we have a stage 2 pressure ulcer injury. So this is just a partial thickness loss of dermis. Shallow open ulcer, red or pink wound bed without slough granulation or eschar. So in the coding tips on page M-13 of the REI user's manual, it tells you there cannot be slough granulation or eschar in a stage 2 wound. A stage 2 wound doesn't anatomically go deep enough to grow those. In order to grow those types of tissue, it has to be deeper than that shallow ulcer. So a lot of times there's misunderstanding, even from wound clinics, where they'll say there's a stage 2 ulcer with granulation in it. And for MDS purposes, that is not the case. Either it's not a stage 2 or it's not really granulation. So you really need to make sure you're sharing this information with the outside folks that are doing any wound assessment as well. And these are the different tissue types. So we need to make sure we're looking at, is this epithelial versus granulation? These are a couple of pictures that show us that difference. Epithelial, light pink, new growth, coming from the middle of the wound for a stage 2, coming from the edges from a stage 3 or stage 4. And then the granulation tissue is that red, beefy cobblestone appearance that's going to be at a stage 3 depth or deeper. Stage 2 pressure ulcer injury could also present as an intact or open or ruptured blister. Again, you need to determine what's the difference between this being a stage 2, which has kind of defined area, versus that suspected or that deep tissue injury where it's maybe mushy, boggy, bruised looking, purpley, maroon looking, and we need to determine the difference between the two. Stage 3 pressure ulcer, this is a full thickness tissue loss. Subcutaneous fat may be visible, but bone, tendon, or muscle are not exposed. Slough may be present, but as long as you can see the deepest anatomical depth of that wound, you can still stage it. If the slough or eschar is covering the wound base, we cannot stage it. But if it's on the sides, you can see that deepest anatomical depth, the slough or eschar could be in that stage 3, most likely slough. Here we have a picture of a stage 4. This is a full thickness tissue loss with exposed bone, tendon, or muscle. Cartilage serves the same purpose as bone. So if it's cartilage that's exposed, that would be a stage 4 as well. So maybe on the ear, the bridge of the nose. Slough or eschar may be present in part of the wound, but again, if you can see that deepest anatomical depth, and you can see that it goes to that full thickness, you can stage that. Often it includes undermining and tunneling, and the depth is going to vary. So when we talk about depth, we're talking about anatomical depth, not measurement depth. You could have a very shallow stage 4 pressure ulcer on the outside of an ankle, or you could have a very deep stage 4 pressure ulcer if you are looking at the ischial tuberosities. So anatomically, you need to know where are we and what are we looking at. And one of the items that CMS has put in their online training, which I have a link to in the slide deck, is that we're looking at palpable. It's not just visual, it's also palpable. So what are we looking at, or what are we feeling? Is this bone? Is this cartilage? Is this tendon? And they do mention in the REI manual and in the CMS training, palpable is part of that assessment. Then we have our unstaged pressure ulcers. Unstageable due to a non-removable dressing or device. Obviously, if there's a cast or a wound vac in place, we can't see what's under there, but there has to be documentation that there is a wound under there. We can't say, oh, they're coming in with a cast, you're going to know that they're going to have a black heel. No, there actually has to be documentation to say it is known that there is a pressure ulcer underneath it. We just can't stage it because of that non-removable dressing or device. So you cannot capture this unless you truly have documentation to prove there is a pressure ulcer or injury underneath that device. And then we have unstageable due to slough or eschar. We do have a wound. We know it's a pressure ulcer, but we can't stage it because the wound base is covered. We do not know how deep it goes because there's slough, there's eschar covering that wound base, and we cannot see the deepest anatomical depth. This is going to be full thickness tissue loss. It's going to happen at a stage 3 or higher. As I mentioned, stage 2 does not grow slough or eschar. If you can see the wound base and you can measure the deepest anatomical depth to determine whether this is a 3 or a 4, you can then stage it, even if there is still slough or eschar. But if it's completely covered, we have to code this as an unstageable due to slough or eschar. And then we have a couple more pictures of the difference between slough, which is that non-viable yellow, tan, gray, green, or brown tissue, and then the eschar, which is dead or devitalized tissue. It's important to understand the difference between eschar and a scab. Scab is part of the healing process, whereas eschar is that dead tissue. And then we have our unstageable deep tissue injury. Obviously, it's not open. We can't see how deep it goes. The difference between a stage 1 pressure injury and a unstageable deep tissue injury is the deep tissue injury could advance much faster. It could be much deeper and much more involved. And once it opens, it's going to be staged, and it could be very easily and quickly staged to a 3 or a 4. So that's why it's very important to try to assess the difference between that pressure injury stage 1 versus a deep tissue. There's probably a lot of different interventions that you're going to have in place depending on whether it's the stage 1 or stage 2 versus the deep tissue injury. So we're really looking at that area of discoloration that is preceded by firm, mushy, boggy, warmer or cooler area. And it sometimes is going to be difficult to detect in folks with darker skin tones. Then we have our venous ulcers. This is an ulcer caused by peripheral venous disease. And then we also have some potential hemosiderin staining, which is that leakage of the iron content that shows as a dark or yellow-brown pigment on the wound. And it could start by a minor trauma. It's usually in the lower leg area, medial or lateral malleolus, irregular wound edges, leg edema, and that staining. And then we have arterial ulcers, also could start due to minor trauma. Usual location, toes, top of foot, distal to medial malleolus, characterized by necrotic tissue or pale pink wound bed, diminished absent pulses, and then you have that dry skin, loss of hair, brittle nails, muscle atrophy. Diabetic foot ulcer. So this is going to be an ulcer that is caused by the neuropathic and small blood vessel complications of diabetes. Just because somebody has an ulcer on their foot does not mean it's a diabetic ulcer. So if you have somebody with an ulcer on their heel caused by pressure, even though they're diabetic, that is not a diabetic foot ulcer. That's going to be a pressure ulcer. Diabetic foot ulcer is going to present more like what you see on the screen there, that kind of punched out plantar surface, and it's definitely different. And certainly that pressure ulcer on the heel is exacerbated by the fact that they have the diabetes, but it doesn't make it a diabetic wound. And then we have surgical wounds, any healing and non-healing open or closed surgical incisions, skin grafts, or drainage sites. You're not going to include any healed surgical sites, healed stomas, or lacerations that require suturing or butterfly closure. PICC sites, central line sites, or peripheral IV sites do not count as surgical wound. Coding surgical wound is appropriate for pressure ulcers that are surgically repaired by grafts. So if you have a staged pressure ulcer that is repaired by a graft, that is now a surgical wound. And even if that graft fails, it's not going to revert to a pressure ulcer. It's going to continue to be a surgical wound until it heals. And then skin and tissue injury caused by heat or chemicals are burns. We're looking at 2nd degree and 3rd degree burns here. 1st degree burns are not coded on the MDS, but they do have to be care planned. And then, as I mentioned, we've got our additional training that CMS has provided where they have some more information about coding Section M. Any one of these items in Section M or Section K could really be a triggering point for a significant change in status. What you really have to look at is, does this resident's plan of care need to change? And if it does, you may want to look at completing that significant change in status. I know we were top of the hour. I do see a couple of items in the chat. For the evaluation link, Mary and Jill, it says that there was some issues, so I don't know if maybe you want to look at that link again. How would you code blood blisters on toes caused by the resident stepping on their own feet during a transfer? Well, that sounds like an injury. It could potentially be a deep tissue injury, or it could be something venous if they have other things going on. If they have, peripheral vascular disease of some sort, it could just be a trauma. It could just be an open bruise that opened up, which you may not have a spot to code it on the MDS. Care plan for sure. But it doesn't necessarily have a spot. Sometimes you're going to need to powwow with the team and say, well, is this a trauma? Is this a skin tear? Is this a shear? Is this a blood blister? Is it a deep tissue injury? Do they have the peripheral vascular disease? What else is going on? So with these wounds, any of them, you shouldn't just be looking at them in a bucket. Just one person. Ideally, you're going to have a wound champion in your facility, hopefully a wound team where you can have discussion about the different types of wounds and what they look like and what you think they may be. But if you're not sure, we have physicians, we have physician extenders that we can reach out to and ultimately find that cause, because once we find the cause, it's going to be easier to hopefully heal the wound, because you're going to have different treatment interventions. I mean, they may have a traumatic wound, but then, oops, all of a sudden that was the precursor to determining, oh, they've got vascular issues because this wound is not healing. Maybe we need to send them to, get an ultrasound or, blood flow test or whatever it is to see if there's something else going on. I think we have time for one more question. It's a technical question. Would it be possible to get the webinar slides? I will leave that up to my co-hosts to make that determination. And then, and they will be sent out. Very good. And does the physician prescribed weight change cause a sig change with one other change of condition, change in ADL, even if the weight change was expected and wanted? That is a great question. Wow. Let me think on this for a second. So we have a decline, but it's expected. That is part of the plan of care. And when we're looking at the significant change in status, anytime you have a planned change, that and care planned as a planned change, that is not going to trigger a significant change in status. So if we know that, like, say, for example, you have somebody who's hospice, they're dying, we know that they're going to continue to decline, and we've got care plan in place for that, and everything is in place. We don't have to keep doing significant change in statuses because it's care planned. We know they're going to decline. But if same thing, if we know they're going to have a weight loss or a weight change and it's planned, I would not consider that as part of the significant change in status unless there's something else going on. Like, yeah, we planned the weight loss, but here's what else happened because of that weight loss, which may be difficult to determine. You may need to do that full analysis. I'm of the school of thought, when in doubt, do the sig change, because it's certainly not going to hurt to look at the, the resident more in depth and make sure that their care plan is tight. And I don't see any more questions in the chat, so I am going to turn it back over to Jill to close us up. And if there's any other questions, you feel free to unmute yourself and shout out.
Jennifer, thank you. That was a lot to cover in a jam-packed hour. So thank you so much. We appreciate the engagement and the questions. And Jennifer, thank you for providing your email address. So folks have, if they have questions, I assume that they could reach out to you.
Please don't be shy. Don't be shy. I love answering questions.
Well, thank you for that. That's very much appreciated. We're thankful for everybody who was able to join today. And as you saw in the chat box, we will be sending out the webinar link and slides. We'll also post these on our Mountain Pacific website. So again, thank you for joining us today, and we look forward to next time.
Thanks, everybody.
Be well, everybody. Thank you.